Good evening and welcome. I'm going to hand over to Dr. Nkube. Dr. Nkube, over to you.
Yes, thank you, Rene. Good evening and welcome to yet another edition of our policy dialogues on human resources for health. Today we'll be discussing RWOPS, remunerative work outside public service. So this is a very important policy that has had two main objectives. Number one, to retain healthcare workers in the public service, but number two, also to develop skills that are not available in the public sector. So this policy has really been subject to a lot of debate for several reasons, which will be unpacked during the course of this panel discussion. We have today a very elite panel of leaders. We'll be having Dr. Busisiwe Matiwane, who holds a PhD in public health from VETS. Her PhD was really entirely on RWOPS, and we will be seeing some of the findings from her studies today. She's a researcher at the Health Economics and Epidemiology Research Office in the University of Witwatersrand, and her research focuses on health policy, human resources for health, as well as health systems. So after a presentation, we'll have a discussion which will involve Dr. Nhlakanipho Gumede, who himself is currently the CEO of Gray's Hospital. He's the chair of the Senior Doctors Association of South Africa and treasurer of the Rural Doctors Association. With him will be Professor Mtambira, who's a urologist at the George Mukhari Hospital. Prof. Mutambira has 80 peer-reviewed publications and 10 book chapters. He's also the academic chair of the Urological Colleges of Medicine, amongst several other accolades that he has. Also joining him is Dr. Kwinda. Dr. Kwinda is a family physician who holds an MMed in bioethics and law. He's presently the CEO of Chiamiso Trust. His previous roles include the HPCSA Ombudsman, Vice Chairperson of the Medical and Dental Board within the HPCSA, and has also acted as a registrar at the HPCSA, amongst other roles. And so we do have an elite panel, colleagues of healthcare leaders who will be discussing RWOPS with us today. So we'll move straight in the interest of time to Dr. Matiwane's presentation. Thank you, Dr. Matiwane.
Okay, let me just share my presentation. Are you able to see it?
We can see it. Thank you, Doctor.
Thank you. Good evening, everyone, and thank you for taking time to attend the seminar. So as I've been introduced, I'm Busisiwe Matiwane, and I'll be presenting my PhD findings. The PhD was supervised by Professor Letitia Rispel and Dr. Dwayne Blau. So my study was entitled Multiple Job Holding Among Public Sector Medical Doctors, Professional Nurses, and Rehabilitation Therapists in Gauteng and Mpumalanga. Okay, my mouse is not moving. Okay, there we go. So I was able to publish 3 papers from this PhD. Okay, so the papers are available online. I published in BJ Open, PLOS ONE, and SMJ. So multiple job holding is working more than one paid job simultaneously, and it's common in health labor markets. It often involves public sector workers taking private sector jobs. Policy responses from different governments vary. Others prohibit multiple job holding, while others allow it with restrictions, and others promote it in the public sector. So it's influenced by legislation, private sector job availability, and also pay gaps between the public and the private sector. The implications for the individual health professional can be fatigue and burnout. And then for the health system is reduced public sector availability of crucial health professionals. So within our context in South Africa, the private sector is well developed and lucrative, while the public sector is functional, but it is overburdened. In South Africa, multiple job holding is permitted with restriction by the RWOPS policy and was adopted by the public sector, health sector, as an aim to retain especially medical doctors in the public sector. There has been reports in the past of non-compliance and abuse of the RWOPS policy, and a recent study has found that there is inadequate monitoring of multiple job holding and fiscal constraints on health professionals, because when they're not available, it's like paying for services not rendered. The 2030 Human Resource Plan for South Africa has emphasized a review of the policy, and this has been indicated as a priority for human resource for health. So, okay, I think something went wrong. Okay, what did my study look at? So, you may be asking yourself, what is the point? Why is there a gap? So the gap was that the existing studies on doctors and nurses at the time were outdated, and there were limited studies on research on the RWOPS policy, motivations for multiple job holding, and reasons for the reported non-compliance. And there were also no studies on the preferences of health professionals for MJH regulatory interventions. So the aim of my study was to investigate the experiences, extent, contributory factors, and regulation of multiple job holding among public sector medical doctors, professional nurses, and rehabilitation therapists in the 2 provinces. So my study was a mixed method study. So I used both qualitative and quantitative. The qualitative component included 33 key informant interviews with stakeholders across South Africa. Those were from academia, professional bodies, associations, and also government, provincial government, and national government. And then I also had 30 in-depth interviews with health professionals involved in multiple job holding. And lastly, I had the quantitative component was a health professional survey, including a discrete choice experiment. So the survey was conducted in 14 hospitals in Mpumalanga, and 15 hospitals in Mpumalanga and 14 hospitals in Gauteng. And data collection of both the qualitative and quantitative component was from 2021 to 2022. So just to give you an idea of what I will be discussing in the next few slides. So firstly, I'll touch on the survey participants, the prevalence, forms, and motivations of multiple job holding, the views and all perspectives of the health professionals on the current RWOPS policy, their preferences for different other regulatory mechanisms for multiple job holding. Those are from the DCE results, and also whether they get approval for their RWOPS for their MJH jobs, and also lastly discussing the policy implementation in public sector hospitals. So in terms of the survey participants, in total I surveyed 1,397 hospitals, professionals in the 29 hospitals. And in terms of speciality, 44.4% were medical specialists, and then only 32% were actually had nursing specialty. And then in terms of overtime, the doctors obviously had the highest, because doctors, as you know, is part of their commuted overtime as part of the contract, and nurses and therapists who have an option of actually having overtime, that nurses actually had a high rate of overtime of 55.6%, and then rehab therapists had only 31.2%. So in terms of what the health professionals said, like when asked if they had additional jobs, so we found that the prevalence of multiple job holding was highest among the rehabilitation therapists at 38.7%, followed by medical doctors and nurses. With the doctors looking at the different groups of doctors, orthopedic surgery had the highest at 77.4%, followed by surgery and anesthesia. And then in terms of the rehabilitation therapists, physiotherapists were also at the highest at 53%, followed by speech and audio and occupational therapy. With nurses, those nurses that had an occupational health specialty were highest at 25%, followed by those with child nursing and critical care. And then in terms of looking closely to the medical doctors, the medical specialists as a whole had a prevalence of 52%, followed by the medical officers at 18.9%. And these differences, especially for the medical doctors, were significant. So when asked where the health professionals actually work and engage in multiple job holding, so the medical doctors and the rehabilitation therapists mainly engaged in their own private practices, and then they also engaged in other people's private practices working as locums. And non-clinical work was actually not as much, not a form of MJH they engage in. So but with nurses, most of them engaged in nursing agencies, and then followed by non-clinical practice, non-clinical work. So the non-clinical work was mainly academia owning their own businesses across the three groups. So in terms of the reasons why health professionals were engaged in multiple job holding, these results are both from the qualitative and the quantitative component. So the pull factors for the three categories were mainly financial. So the reasons they reported were income supplementation, financial stability, debt repayment, and others aspired to have a better life. And in terms of secondary motivations, people were looking for job variety, so they just wanted something different to the normal medical, especially if they engaged in academia, and others just wanted to experience better things or equipment in the private sector, and also career development and professional fulfillment, especially for rehabilitation therapists and doctors. And then the push factors, we found that public sector inefficiencies such as poor management, insufficient accountability, and inadequate resources in the public sector actually pushed health professionals to play the role in pushing health professionals to the private sector. So while looking at the factors influencing multiple job holding, so these are the predictors. So this we get from the regression analysis. We find that being a specialist, having dependents, and living in an urban province increase the likelihood of engaging in multiple job holding for doctors. While for nurses, being married increased the likelihood, but being a clinical head of department reduced it. And then for therapists, being male increased the likelihood. Okay, so in terms of their views or perspectives of the current RWOPS policy, we will ask them certain questions, and then this is their yes response to actually the questions that you can find on your left. So in terms of whether there should be mandatory RWOPS approval, the health professionals, especially doctors and therapists, agreed that there should be mandatory approval, but the nurses were not as keen. And then in terms of RWOPS only being allowed after working hours across board, all three professional groups agreed that RWOPS should only be undertaken after working hours. But in terms of limiting the total number of MJH hours or RWOPS hours, all three professional groups actually did not agree that RWOPS hours should be limited. And then when asked if they would leave the public sector if RWOPS was banned, all three groups said, so this was highest among the doctors, followed by the rehabilitation therapists and the nurses. So this is just to provide more context into when I give you the DCE results. So as I said previously, that in terms of policy regulation for multiple job holding, you have your limiting policies, your reward policies, and in some countries you have self-regulation, where peers and statutory bodies actually regulate multiple job holding instead of an existing policy. And this is mostly in high-income countries. So the DCE that we had undertaken, so a DCE is a quantitative tool used to elicit people's preferences. So then we wanted to find out what preferences in terms of multiple job holding, what policy preferences do health professionals want. So then we offered them a job with a combination of the restrictive and also the reward-orientated policies. And in terms of the restrictive policies, we offered them different conditions of multiple job holding. So we either banned multiple job holding or either increase or decrease our RWOPS hours. Then in terms of the reward-orientated policy, it was salary, clinical practice environment, hospital management, and employment contract. And then this is what they preferred. So across the three groups, health professionals significantly opposed a ban on MJH as a policy option. And then they valued salary increases, adequate staff and resources, and competent hospital management. But then doctors and therapists valued higher overtime, whereas nurses did not. So when we're looking at the amount of salary or percentage of salary, health professionals are either willing to actually forego or willing to actually be paid to actually be compensated for these policy options. When it comes to RWOPS being banned, doctors actually wanted salaries as high as 45.7%, nurses 20%, rehabilitation therapists 42.8%, for them to accept a ban on MJH. And then when it comes to having a facility that had required staff and resources, the doctors were willing to give 57.9% of their salaries, nurses 54.8%, and rehabilitation therapists 38.9%. Where, okay, competent management was important, but not as important as the other two policy options. So now, when we then looked at banning MJH as a policy option, we found that health professionals could be compensated by actually salary increases alone, or a well-equipped clinical practice environment. However, improved hospital management alone would need to be paired with other incentives for them to support retention. And then when we combined competent management and well-equipped facilities, this actually further improved retention, even if we banned MJH. So in terms of compliance, this was asking them if they had actually approval for the jobs they had. And then we found that medical doctors and therapists had approval for their MJH or RWOPS, but then only a small percentage of nurses actually had approval. And then with the regression analysis, it also showed that therapists and medical doctors were more likely to actually obtain approval than the nurses. So in terms of RWOPS implementation, so when this was through qualitative, when we actually asked the health professionals and stakeholders, hospital managers, academia, trade unions, professional bodies, we found that the policy faced ambiguity about the policy. So issues such as people not being sure what actually constituted of RWOPS. So how people will complain about people being allowed to sell products, while when you want to work as a health professional, it became a problem. And also issues with like poor, inconsistent implementation in terms of in Gauteng, it was locally approved at the hospital, and in Mpumalanga, it was centrally approved at the provincial. And also a weak oversight where managers would often overlook medical specialists, especially actually and being non-compliant to the RWOPS policy. And also poor accountability, even when the person was found to be guilty of being non-compliant, actually with no punishment or any other disciplinary action being taken against these individuals. So these challenges hindered effective management of MJH or the RWOPS policy and resulted in uneven compliance across the two provinces. So the following policy implications are just from my whole PhD. So my findings indicate that improved clinical practice environment and better hospital management can reduce attrition and can even offset the impact of a ban. But as we all know, fiscal constraints, deteriorating infrastructure, and weak oversight in the public sector actually limit the implementation of these interventions in South Africa and other low middle income countries. And then in terms of more effective management of MJH regulation, I'd like to highlight 4 key areas. I think the most important thing is improving awareness of the RWOPS policy. So disseminating the current DPCSA directives. So there's a current one that the 2024 one, and also the 2020 guidelines that actually explain the roles and responsibility of the individual health professional and also of the managers who are implementing the policy. And also HR playing a role in in-service training on the RWOPS policy. And then in terms of strengthening and supervision and compliance, active policy enforcement by managers and supervision of MJH health professionals, and communication and awareness campaigns to encourage voluntary compliance. And thirdly, accountability for non-compliance. So developing clear guidelines on progressive discipline for non-compliance and actually enforcing disciplinary action and sections for especially repeat offenders so that people then can trust the policy and see that it's effective. And then lastly, this is just for further research, more research and evaluation on the impact of the RWOPS policy, if it's actually achieving its role to actually retain medical doctors and other health professionals that are crucial. Then, in conclusion, multiple job holding is valued by health professionals for additional income and professional development, among other reasons. So, as we have seen, that health professionals were strongly opposed an MJH policy ban. And then clear rules, active management, supportive clinical practice environment, accountability for non-compliance can play a key role to retaining staff. Hospital managers, health professionals share a responsibility to supervise. So supervising your peers, supervising your subordinates, complying with the policies, so for both the managers and the health professionals, so that we can protect public sector patients. Thank you for your time. I'd like to acknowledge the following, and thank you, Sama, for the opportunity to present my PhD findings. My email address is below.
Thank you so much, Dr. Matiwane. That was very insightful, and I can see some accolades. There's hearts, there's clapping of hands, and all sorts. Yes, thank you. That was brilliant. And so there's a few questions, and I'd like to start with questions from the floor before we get to our panelists. So you've been asked to provide the definition of multiple job holding and whether it's allowed in the public sector in terms of the legalities around it. So that's the first question.
Okay, can I answer?
Yes,
okay.
yes.
Okay, so multiple job holding, as I said in the first slide, is like, let's say you as a doctor having another paid job in the private sector. So the private sector can be you working in the health sector, or you selling Avon, or you having a shop somewhere. So it's just you having another job that pays you. And then in terms of the legality, so the DPSA provides, has made provision through the Public Service Amendment Act, Section 30, that then allows you then, if you apply and complete certain forms, then to be able then to engage in an additional job. Is that clear? I hope that's clear.
Yes, thank you. And then related to what you just said is a question on whether it is true that if you don't get a response to your RWOPS application in 1 month, you can consider it approved.
Okay, yes, it's true. So the 2024 directives that I spoke about earlier, so they had made provisions, because previously they would say to you, after the 30 days, then you can engage in RWOPS. Then you find that doctors, and you find that health professionals then were struggling, because then if you wanted to claim, especially from GEMS, then you'll be asked to say, okay, where is your certificate? So they didn't issue a certificate before. So now they are then saying that people then hospitals and province must then issue you a certificate to show that the 30 days has exceeded. Then you can continue. But the issue with that is that after then they review, then that certificate can be taken away if they feel that the hours that you're going to work in government and private actually are too much and exceed the hours that they allow you to actually engage in RWOPS. But it is true that you are allowed. So now currently you are supposed to be issued a certificate so that you can present it either to BHF or either to GEMS, wherever you need the certificate.
Okay, thank you so much. There's an interesting question about practitioners doing clinical trials and being paid for this by the pharmaceutical industry. Would this also constitute RWOPS, and should it be managed the same way?
Yes. So as I said before, RWOPS is you getting paid. So whether you're getting paid 2 rand, 1 rand, so whatever job that you are getting paid, wherever you are working in whatever capacity, that is RWOPS.
Oh, okay.
So whether you're working in a clinical practice, whether you're working at church as a guitarist and they are paying you, it's RWOPS. Selling Avon, it's RWOPS.
Oh, nice. Thank you. Yeah. So how do you reconcile valuing overtime and also saying RWOPS should be done after hours? It seems to be doing, is it not doing both in the same space?
Oh,
So,
okay. So then, so overtime, I know for doctors, you guys have committed overtime, but then for nurses and rehabilitation therapists, then they actually can then engage in overtime. So then because this then is then a government thing, that does not then constitute as in this space. But in other countries, that is considered RWOPS because you are being paid for that type of job. So then when they're, let's say now you're applying for your RWOPS, then they're going to look at, okay, fine, Mshengi, you are working 40 hours, then you've got 20 hours of overtime, then you are saying you want to open another practice. So all those hours will be looked at. So if your hospital has a certain limitation, then your RWOPS can then be declined because then now you are exceeding the time. And then people also complain that why are you then allowed to have a lot of hours in the public sector, but you can't in the private sector? So yes, there's still that debate, which yes, I agree with, but yeah, that's how things are currently. But yes, it's still because it's paid, just that because there's a certain contract that you sign with your employer, it's like you doing RWOPS inside the public sector, which is what they want, not you doing it outside, because they're gaining when you are servicing patients. And the other part of the question, did I address everything?
I think you did.
Okay.
I think the last question would be, if my family has a business that gives me income and I do not work in that business, is that RWOPS?
Okay, so the tricky thing with that is that if, for instance, that company is a registered company, and then you are probably, when you are paid, there's a pay slip or something. So now with the financial disclosure that has been added, I think since 2018. So if let's say you apply and then when they assess your thing and then they pick up, because sometimes you find that maybe you own a caravan and your sister, and you bought it for your sister who's having a business that you are not involved in, but because it's registered in your name. So as soon as they put your name in and all those businesses come and click, then you'll be denied RWOPS because it's saying that you are overcommitted. So that's sometimes the difficulty that some then people find, because somebody will be saying, no, that caravan, I bought it for my sister, I don't work there. But in the instance of this person who is paid by, they are paid but being paid, then that's considered RWOPS because whatever services or non-services you are, whether it's through family or whatever, you are being paid. So that is going to be considered RWOPS. So the sad part is for those individuals who are not working in those companies, then that's still an area where we need further clarity.
Okay, thank you. Thank you so much, Dr. Madiwane. I think our panelists then will have a chance to as well ask. I suppose it feels like you're defending your PhD right now.
No.
Okay. Prof Mutambirwa, do you have any questions for us? Yes, Prof. Okay.
If the president is having a farm, he gets that's RWOPS, isn't it? If I'm not mistaken. And if that's the case, then the limitations are going to be applied to everybody, I assume, at the end of the day. It's not just going to be to medical doctors if they decide to limit the RWOPS.
Yes, because with the new financial disclosure, because you have to complete it online and then you have to disclose everything that you own. But sometimes you find that people then forget to disclose certain things. Then they find that their RWOPS is then not approved. But then everything you own, if then gets picked up by the financial disclosure. So that's the current issue at the problem at the moment.
Thank you. Thank you. Any questions, Dr. Kwinda?
Thank you. Good evening, and thanks, Dr. Matiwane. I really enjoyed your presentation, and I'm looking forward to read your whole thesis.
Good luck.
But just of interest, really, from my side, is the role of BHF or the role of the medical aids. What role do they have, and which legislation empowers them to demand a certificate? Because the process is quite very simple in terms of the Public Service Act. You apply, you receive, they grant you permission or they deny you permission. And if you don't receive a response, then permission is granted. Why should I wait for a certificate? Because the fact that I have applied to indicate that I applied on this day should be sufficient. But my question really is, what powers or who empowers the BHF or a medical aid to do what they are doing, where they say, we are not going to pay you because you do not have a certificate? If you can just clarify that.
Okay. In terms of, let me give you a bit of history. So the Department of Public Service Administration, DPSA, so they actually went into communication and in collaboration with BHF and government and James. So that was to try actually and monitor health professionals engaging in multiple job holding. So then they went, then there was now a requirement that if you apply for a BHF, then you need to put your ID number. So then putting your ID number then picks up that you're a health professional. So they were trying then to, so it was just a mechanism of them to monitor health professionals, so that because in the past, health professionals then would then engage in multiple job holding or RWOPS without permission. So now when that was in place, then you could not obtain a practice number without actually your RWOPS application. And then in terms of the medical aid, it's a similar thing with the BHF. It's just so that government is trying to actually then limit and make sure that people are not engaging in multiple job holding without a permission. So that's the issue, that because of this collaboration, then that's why now you need the certificate. But the other thing that's an issue with that I have an issue with that, is that then it only monitors you as a health professional if you are engaging in clinical practice. Let's say if you're working as a doctor or a physio or as a nurse. But then if then you have a business that's not registered, then those people are lost in the gap because they don't require BHF, they don't require to go through a James claim. So that, because now then health professionals are feeling like there's like a focus point on you then working as a doctor. But then I think because the public sector is trying to retain you as a health professional, they haven't found means of then, that's why they introduced the financial disclosure, so that it can also pick up those other businesses that you have, so that then you can also be covered, they can be covered in that area. I hope that answers your question.
Can I just make a follow-up, Thengi?
Yes.
On this one, and just another point that I'm going to make. So basically, it's when you have got a practice number. And I think we need to put it very clear that for one to run a private practice, you don't necessarily need a practice number from BHF, especially if you're going to be a cash practice, because your patients can pay you cash, and you give them an invoice or a statement of account, and they go and claim from their medical aid. So you don't necessarily need a practice number to run a private practice. So that kind of a scenario will fit for those who are looking for a practice number or who have applied for a practice number. And that's why I want us to be very clear that really the BHF does not necessarily have a role to play here, especially if one is not looking for a practice number that side. But the other point I want to make as well is that the banning of RWOPS is not provided for anywhere. I mean, these circulars that are released banning RWOPS, how RWOPS is managed is clearly prescribed in terms of Section 30 and 31 of the Public Service Act. It's basically application, granting or denying the permission to perform. And if one performs without permission or without applying, then there is a provision in terms of Section 31 for the authority to recoup that money and have that money paid into the revenue. And it even makes a provision for legal proceeding to get that money. So when provinces are banning RWOPS, that is unlawful. They must just deal with the issue of apply, we don't grant you, and these are the reasons why we are not granting you the permission.
Yeah, just to add on that, I think it was in 2016 when Mpumalanga province actually banned RWOPS. And then the DPSA had to intervene to say that no, that's illegal. Because I think people forget that RWOPS provision is not a public sector thing. It's a national policy for all public servants, so not only health professional. So the provinces and everyone else, we adopt the policy, but it's not something that it's our policy. It's a national policy that is provided in Act 30 and 31, but then we do not then as the other provinces then have legal authority to say that people are not allowed to engage in RWOPS.
So Busi, just to come onto that point then, so who is allowed to give permission? Because in some places it's the province, some places it's the CEO, they keep going back and forth, they don't tell us which one, and they don't. So who is allowed to give us who is supposed to be giving us the RWOPS permission?
Okay, so the tricky part is that the directives, they say that it's the executing authority. So that can be, so they say it's the executing authority, and then so like the HOD of the department. So that's the person at the province. But then I think in Gauteng, they were doing it like it goes, so you go through your manager, then you go through your CEO, like the committee. So what happened is that in 2016, they then said hospitals must have an ethics officer. So then through your supervisor, it goes to the ethics officer or an RWOPS committee. And then from then it goes through the CEO, who then decides to grant it or not grant it. And then in Mpumalanga, it was going through the same process, but then there was an additional step where there was a provincial ethics officer, and then it was then signed either by the HOD or MEC. But now recently, I've also heard that Gauteng is also then going that route where after the CEO, then it's still then going to the provincial office. So that's the route they're now picking up now. And people are not happy because that route takes longer, because my qualitative findings found that because it's a centralized approvals actually took in Mpumalanga, some of them took 8 months. So because there was one officer looking at all the applications, yeah. So it's still, so the directives do say HOD, but the things, the directives are also open to say you as then when you adopt the policy, you can then write to say who needs to then approve, and then everyone needs to be clear. But then people do different things, and then it becomes confusing for the person who's applying.
So what can we do about that? Because that's completely confusing to me as well. I mean, the point is that how are we supposed to do this then? Because the point is, if they say that you're not allowed to do RWOPS and it's coming from all different places and we don't know, is there no policy to tell us what's going on? And I mean,
no.
I know,
so,
yeah.
No. So if they say you're not allowed to do RWOPS, then you can report it to DPSA, because that's the, so the DPSA, then you can, because that's what happened in 2016 with Mpumalanga. So when they said they are banning the DPSA, the people reported, and the DPSA then intervened to say, no, you need to allow people then. So then Mpumalanga then started allowing people then to engage in RWOPS, because you can't then, because even now you need to also provide reasons. Like if somebody declines it, then they need to give you a reason. Then you can also then go back to say, to actually like fight and say, no, but I want to understand this and this and this. So you have a right to do that. And you can report if you find that either your hospital or your manager is not complying, you are allowed to report them to DPSA.
Maybe can I just come in there, Dr. Matiwan, Dr. Mtlengi? I think the issue is the confusion that is brought by the directives and also delegating a function that has been given to the executive authority, because the executive authority is defined in the Act. Right from national, the president, at a province is the premier, at a departmental level is the member of the executive authority, that is the MEC. But we do know that also in terms of the Public Service Act, there is a provision for delegation of that authority. And we just need to be clear, because the confusion, Prof, is because sometimes when these powers are delegated down, then we lose track of who is now responsible. But in terms of the Act, is the executive authority, and executive authority is defined in the Act. So if there is a confusion, we need to go back and say at a provincial level, to who is this function or power delegated? The other processes of you need to apply to your supervisor, who will get to the CEO and so on. Those are administrative processes, but the approval authority is quite very clear in terms of the Act, is the executive authority.
Yes, thank you, Dr. Kwenda. But I think what Prof has issues with is that when now this delegation occurs, then that's when the problem happens. So yes, because then you find that in Gauteng, then the delegation was to the CEO, and then in Mpumalanga, it was to the MEC. So then now when they want to change, then that's the issue, because I think the issue is the communication to people to say, okay, fine, these are the steps, and this is the person who's going to approve, so that people then can follow up the steps. And then also then, but then because then there's no clarity, then it's also difficult for you to then report, because you're not sure who's then responsible, who's actually supposed to be held accountable. So as much as we can say that health professionals are not actually being compliant to the policy, the managers also themselves are not compliant, because then now you say it's 30 days, then you exceed the 30 days. That's not being compliant to the policy, because the policy says in 30 days, a person must get a response. So if the person does not get a response, you are not being compliant to the policy. So so the issues are also both ways.
And maybe just to come in there, the issue is, while the executive authority is the approving authority, there has to be a recommendation. That's why you've got these processes where the supervisor, the manager, the CEO has to recommend to the executive authority for the granted. But irrespective of what, remember the principles of delegation is that the person who delegates is not divested of the powers that they've delegated. So at the end of the day, the executive authority is the one that is responsible.
Yeah, then you end up with delays when the executive authority does not then approve.
Yeah. You are chairing, Dr. Atiwane. I don't see Mtlengi.
No, I'm not chairing.
Yeah.
Prof, you can speak.
Yeah, no, I was just asking. I know your PhD, which is really brilliant, is with Gauteng and Mpumalanga. Is there a bigger difference between some of the other provinces, like for example, the Western Cape? I'm sure you didn't you weren't doing it there, but I think some of the provinces seem to be running in a bit more different ways. And I don't know what your input would be for that, for at least for the medical part for Ottawa.
Okay. So in terms of, okay. Okay, so in terms of Western Cape, so I'm not sure what their steps are, but I know that it's better monitored than in Gauteng. I've read previous papers where, especially at Grooteskier, where different departments had different things, where they either reported on the total number of hours, but then there was also like differences in departments. So you'll find that in Prof's unit, like in your unit, we say, okay, fine, let's write all our RWOPS hours and then all our overtime. But then in another department, you find that the professor then has a laissez-faire thing and he's like, okay, you can do whatever as long as your job is done. So that was the differences I've read in the literature. But that's old literature from I think it's 2015 or 2012. Yeah, but I'm not familiar with that process. But currently where I'm working at Hero, we are actually doing another study where we are looking at regulating job practice in low and middle income countries. So we will be looking at South Africa and Mozambique and looking at exploring the different MJH regulations that actually would advance universal coverage. So we'll be covering the Western Cape, we'll be covering Mpumalanga, Gauteng, and then, yeah, so that's, so we're hoping that then we'll come back here and provide feedback on those results.
Yeah, maybe let's get Dr. Gumede to come in. Doc?
Thank you, Chairperson. I know that you are now the chairperson of this, but I do want to appreciate the opportunity and appreciate also the presentation that is very much details in terms of the work that has been done with regards to RWOPS. I think that you've been able to highlight quite a number of issues that I think are very pertinent and important. And one being a shared responsibility between the person who's an applicant and also the manager that is responsible for making sure that the policies are adhered to while ensuring that the public service is actually not compromised. And I think that one question that I would have perhaps maybe to you is, has there been work that has been done that seeks to associate the interest of the private hospitals with regards to their need for specialists and them having to tap into the public service for that? As a result, you find them going around and looking for specialists in the public hospitals to ensure that they still continue to provide service in their own private hospitals. So you have a lot of private hospitals at the moment that are mushrooming, and there is really a high demand in terms of specialty and all of that. And often we see that there is actually now what I would call a parallel interest rather than just a self-interest of doctors to be able to participate in OROs, but also being approached to be to form part of a team that seeks to establish certain services within the private sector.
Okay. Thank you, Dr. Gumede. So I haven't seen any like studies, like published studies on what you are speaking about. But from my qualitative interviews, when I interviewed, especially the private sector, they were saying that they, even the public sector managers, they were saying that actually we find that most of the doctors are actually working for both sides. So you find that Dr. Gumede is a surgeon in public and is also a surgeon in the private sector. But then the main thing that they also mention is that in the bigger cities, you find, especially like Gauteng, Western Cape, you find that that problem is not such a big issue because there's a lot of private sector doctors because they want to live in the city, and also there's a lot of patients. But then the problem then becomes in those small places. So because I remember one private sector key informant actually mentioned that that's where the struggle is, because now even with them, you find that now there's a patient in private and then the doctor is still busy in government, or they have to drive an hour to come to that hospital. So the issue was not only for the public sector, but also for them as the private sector. So, but then the main issue that they raised was that especially in those small remote areas where actually the private only doctors would not want to go and work. So that's where the demand was the biggest area, where then government and private were fighting for the same people. Yeah.
Thank you for that. Just a follow-up question, perhaps. just to ask whether or not then, if that is the case, do you think that there is a responsibility of the private healthcare facilities to be able to contribute in terms of how we manage the RWOPS so that they don't go out of order?
Yes, there is a responsibility because we are sharing. Because the things that at the end of the day, as much as they feel that the public sector has its own managers and they need to, but at the end of the day, we're all servicing patients. So our ultimate goal is provision of care, whether it's private care or whether it's government care. It's just provision of care. That should be the central goal. So the central goal shouldn't be at my home we are fine, so you sort yourself out. So there is a responsibility because of that. But then I think also the issue also in government is that we also need to, because the things that we need to also sort out our house, so that when you come in and seek for help, then have your things in order, so that when somebody else comes, you say, okay, fine, I've implemented A, B, and C, I need help here. So when that hasn't happened, then that becomes an issue. Because if the private sector then comes and then sees that you don't have any existing structure to monitor an incoming and going out of your health professionals, so then they're like, okay, where are we going to start? So I think we need to put those systems in place so that when we are seeking for help, at least somebody is meeting us halfway, not like dragging us out of a hole. So I hope, that is clear.
Thank you so much. Thank you.
Pleasure.
Maybe I can put the ball back into your court, Dr. Committee, because you're a manager, you're running the hospital. I just want to understand some of the, because we like to say we must give service delivery. That's true. But like, for example, in my unit, we used to have 10 operating lists per week. Because of non-appointments for anesthetists, because of non-appointments for our staff, we've gone down to 5. Some of the days we don't have lists. What is where how as a CEO are you going to be able to manage this? Because the point is that should I just tell my doctors to sit around the hospital drinking coffee and doing nothing, or should they go out and do something in the meantime? I'm asking I know it's not part of the RWOPS policy, but I think we also have to recognize that it's actually there's so much service delivery problems, not only because of RWOPS. RWOPS is a small part of it. There are a lot of other things. And where am I going to get, for example, robotics is now the biggest thing in urology. We have no robots in the hospital. We send out patients to go and get our registrars to do things out in the thing. Should our doctors on a day like, for example, where there's no operations, I know it's legal, but it makes more sense if they're going to go to our private hospital and they're going to be trained there. So I just wanted to understand what management in total is thinking about this.
Thank you very much for that question. I think in your question, you actually mentioned a very important issue in terms of saying that RWOPS in itself is not just a sole problem, but we've got other issues, I think, that are problematic within the system and that are actually hindering in terms of job satisfaction, and such as the case of lack of whether it's specialists or theatres and theatre time to ensure that we keep our doctors entertained with the work that we've hired them to do. I think what is more important here is to have a planned approach in terms of being conscious of the available resources that are in the facility at any given point in time. And that brings about an issue of a strategic engagement with your clinicians in the hospital to make sure that you assess that and I'll give an example of what is actually currently happening in our hospital and in Grays. We have been embarking on an outreach program, for instance, and that enables our doctors not just to be in our facility, but to also go out into other facilities to build capacity. But we also run an academic institution where we've got internship program running, students that are there. And there's quite a lot of things that are going on in the facility that could be done. And we often face challenges where junior doctors say that they are perhaps maybe not really supervised because, senior clinicians are not there in the hospital and all of those challenges. I think that this needs to be looked at as a multidisciplinary approach where we come together, look at it and see how we can make each other more useful in the environment where we find ourselves. And I think that perhaps maybe if we are able to do that and be accountable about the things that we do, there's a lot of things that could be done. And I can tell you, we in Gray's Hospital and the Department of Health, for instance, are not foreign to working together with the private sector. I can tell you we've got memorandum of understandings with the private sector where some of our patients are actually done in the private sector, of course, being incentivized by the private sector, and we do some of the cases. And our doctors, to some extent, will go out to those facilities in the private facility to do operations and all of that. And that comes as an effort from our very same clinicians that actually see that we've got lack of theater time and all of that. And these are some of the ideas that they come with to say that, can we explore this private-public partnership perhaps to be able to contribute effectively in making sure that our patients are actually not left behind? Because of course, I think if you have been, there is a moral responsibility when you have been employed to provide a service within a particular environment. And the expectation is that you should be able to actually make sure that you contribute effectively in the environment where you find yourself. I could have not put it better myself. Other than what actually Dr. Matiwane has already presented in terms of addressing the issues like our pay, addressing the issues of the environment, and our ability to be able to actually keep our doctors more engaged in the service that we provide. So I think it's a shared responsibility. And if we are able to sit together and look at our capabilities, I do believe that we could actually find ourselves in a better environment.
Mhlenge, through you, can I just come in? I think
Yes.
Dr. Gumede, you mentioned a very important point, and I think, Prof, this thing of doctors seeing themselves only as people who are there to see patients and do not think of other activities that they can be involved in the hospital. Let's talk about in-service training. I mean, those are some of the things that doctors can be involved in. And Dr. Gumede is talking about also doing outreach and so on. And I'm saying this because I once did an investigation on RWOPS in one of the hospitals, and the senior clinical manager said something that I was really disappointed with the senior clinical manager, because he said, I mean, doctors go and do ward rounds, and after ward rounds, they've got nothing to do. So that's why they go and do RWOPS. And I said, but can they sit, discuss patients, and learn from their own pain? I'm a family physician. I mean, we believe in learning from your patients. You never stop to learn. And if we can encourage such activities where doctors don't see themselves as people just go do that ward round and then off you go, they have got nothing more to do, then I think we can start to engage our doctors more. But I also want to check with you, Dr. Gumede. How do you handle the RWOPS? I think Dr. Matiwane spoke about it, the remunerative work inside public service now, where doctors sell each other calls. Those who are doing sessions at public hospitals do not come to the hospital. They sell their sessions, especially those which are done after hours. They sell them to full-time doctors. And I'm speaking from, I don't know how it is. I mean, I've been out of the public sector for some time. I know of cases where doctors will contract to do sessions at the hospitals, especially hospitals which are struggling with staff. But that doctor has never been to that hospital for a full year. But their calls are done because there's an arrangement between that doctor who is in private sector and the doctors who are working in the hospital. How do you handle that?
Thank you so much, Dr. Quinde. I think as far as it's something that I haven't been able to actually come across in our hospital, but I do know of those type of issues where doctors who are practicing sessions in hospital would not show up for whatever reason, and they would then never come to the hospital. I think the attempt to actually address that issue has been something that has been going on with regards to management. And I think the issue of reviewing these sessions, as a matter of fact, I think, you know, unfortunately, every time there are challenges with a particular strategy or a policy of some sort, the initial response of managers is to scrap that thing away instead of addressing the reasons why that is a problem, which I think almost of the time, I think it's the same thing with the RWOPS, where once we find ourselves in problems, the first thing that we need to think about is to review, do we continue with this thing or we scrap it? And we miss the point in terms of how we can go about managing that. But in terms of the sessions themselves, I think what has been put in place is that actually, if it so happens that you've got a shared or a certain number of calls that you need to perform, there need to be a reasonable amount of the percentage of calls as sessions that you've been given that you need to personally perform. And failure to do so, then it means that you can actually review that appointment as a sessional doctor, because at the end of the day, I'm giving you a session for you to be able to come in and give certain expertise. And I think it needs to come in with an understanding that doctors do not have the same skill set at times. And what we often see is that a senior doctor would actually then sell the session to a more junior doctor. And in a way, now you are unable to actually get the experience of a senior doctor when that session is actually performed. And that comes as a challenge. And more often, I hear some of the managers actually saying that when you are facing a challenge, I think that we need to be honest with ourselves as well, that you can have a situation where you are unable to perform a session, and just like any other thing, you can be sick, you can be involved in a motor vehicle accident, and you need to actually have somebody else covering up for you. But at least there needs to be an attempt that needs to be communicated with the manager of the hospital, and also be granted permission for you to be able to do that. Not the situation that you find where doctors, you just sign a contract as a session, and then that's the last time that you are seen until the next year that you need to review that session. I think that in itself is something that cannot be allowed.
Yeah, and I think also to add to that is that because in my study, I found that the doctors and the therapists actually wanted more overtime hours in government. So there's a chief director of hospital services in Mpumalanga. So what he did is that he was responsible for 4 hospitals because they had issues with CEOs. So what he does is that he opens up the overtime in all those hospitals. So even if later you're working in hospital A, if there's an opportunity to have overtime in hospital B, then you are allowed to go and work in hospital B. So that, because then people are looking for overtime, but then offering those people overtime. So if hospital A doesn't have overtime hours, but then you can then go service hospital B. So that, I think, also can be a great initiative, because you find that people are looking for the hours, just that there is an opportunity for them to actually get additional hours in the public sector.
Could I just bring in Dr. Quinn? I know I understand what you're saying, but when you consider that, for like, we have a regular academic program and everything, and my consultants do that, but the issue about where they're getting their remuneration from, because, for example, at our hospital, only Department of Health pays them. So technically, they're doing it for free for the Department of Higher Education and Training. How's the way forward with this? Because I mean, I think they're doing their best. Most of my guys, at least, I think. But is there any other way? Maybe we should have a more consistent policy. Because I know some people, some provinces, there is a stipend from Department of Higher Education. But in ours, it's all paid by Department of Health, and it just gets a bit confusing for my consultants if I start telling them, listen, you just have to come and do this, even if you've got nothing to do, you must just go and teach them. They say, but I'm not getting paid by Department of Higher Education. So how can we address that?
Mm-hmm.
Yeah. Is that not the issue of the joint appointment? Because the issue is there's an issue of joint appointment, and there is an issue of rendering clinical service, and also an inherent responsibility to also train juniors. I mean, that is inherent, irrespective of the environment that you are operating in. And I think it goes further in terms of how also you make arrangements in terms of how do you deal with your other non-clinical activities in a facility. But I do understand that there's an issue of joint appointment. I've not operated in that space of joint appointments and how it works in terms of remuneration from the Department of Higher Education and Training.
But I also, just to touch on what Prof. Shingai is saying, is that, for instance, like you are in family medicine, like there's some places where there's space for like theoretical training, but there's some areas where there's space for like surgeons. Like you need to operate. So if let's say I want to teach my junior doctors where it's registrars to operate, and the theater is not working, then as a surgeon, then how do then I perform? Because I can't, as much as I can teach you theory, but then if the theater is not working, then I'm unable to actually perform the service that I am rendered to do. Because I've seen, like in other studies where they've reported that sessional doctors from private even stopped and said, stop paying me, because I come here, every time I come here, the theater door is not working. If it's not the theater door, there's no water, there's always something, and I'm not able to do the job you are paying me to do. So I think I don't know, but I think what Prof. Shinga is also saying is that sometimes then there's a service that you need to provide, but you're unable to do it because of services. Yes, you can teach and do in-service training, but if you are a neurosurgeon, you need to operate. I can teach you in theory, but you need to do it in practice. And if you are not given that opportunity, then what? You see, because also when I mentioned the push factors were also inadequate resources in the public sector, because now I'm hired as a surgeon, but I cannot work as a surgeon. So why are you paying me? So then and also you must also remember that as a surgeon, you also need to always be competent in your skill. So if you're not operating, you lose the skill. So then you find that your other mates are actually operating and doing these advanced things, and you still doing things were written in papers in 1999. So that's the biggest issue then for specialists especially, because then how can I train someone in something that I don't know and I'm losing the skill and I'm not becoming competent? Because also it's also a risk to the other registrars, because now if this person is becoming incompetent, what is he training, and which, like all those specialists that he's bringing up, are they going to be competent? And that has implications for our patients also. So like it's a sliding scale. So we need to be careful to say, yes, you can teach, but then you need to be able to make me do the job that you are paying me to do.
And that's why that arrangement that Dr. Gumede is talking about, where the arrangements which are really formal between the public sector and the private sector can work. And hence, RWOPS is a good thing if it is well managed, because you can also train your registrars in the private sector. And as long as it is well managed, it's quite a very good program. And I believe there's a reason why there's a provision in the Public Service Act for that to be done. And if it is well managed, I mean, we can all benefit from that.
Yeah, that's true. I think the main thing, it's true. Yes, you can come in.
But now, Dr. Matiwan, through you, Dr. Mhlengi, so are you saying that even myself as a pastor, I must get permission to preach the gospel? Or
if you're being paid?
I get permission for the stipend for my transport to go and see the congregants?
Yeah, if you're being paid and receiving money, yes. So even if they give you 50 Rand, 100 Rand, yes, you're being paid.
Okay, thank you. I think I'll direct this question to Prof. Mutambira and Dr. Gumede. In the review of RWOPS, what opportunities exist? That for what we can add or remove or improve in the RWOPS policy as it is being reviewed. That's for you, Prof. and Dr. Gumede.
I'll start up. I think one of the important things is I think RWOPS is necessary, like Dr. Quinta was saying. It's just a matter of how we implement it and how we make sure that we monitor it. And the monitoring is so important. And I think a lot of the things that we're getting at the moment is it looks like it's all from the top heavy and top down, telling us that this is what's going on. We need to, I think, get feedback from people on the ground as well about what needs to be done. And that's why I'm grateful for this opportunity to be here. But I think we need recommendations, not just from management, well, top management, because we're also management, but also just to make sure that we have a discussion so that everyone understands what their roles are. I think the HR policies and the public service policies are a little bit too rigid in some ways. We have to actually integrate it as well. I mean, even now, the majority of I'm so short-staffed that the majority of my guys are doing more than 40 hours overtime, and yet they're still getting problems about the overtime issues. So I think we need to have a better dialogue about this, and I think if that happens, this whole RWOPS thing will probably fall away eventually if and when NHI comes on board. But I think we need to get better dialogue. That's my real point. Thank you.
Thank you, Dr. Kumete.
Thank you so much, Mhlengi. I think for me, in terms of the reviewing of the policy in itself, perhaps maybe we should get a proper diagnosis in terms of what makes us want to review this policy. Is it because the policy is no longer applicable to our time at the moment, or is it because we are just incapable of monitoring and supervising, ensuring that we actually adhere to the principles that underpin this RWOPS policy in itself? I think we miss a point somewhere, somehow, when we start reviewing things, in a sense that we want to review something just because we find it as a problem to actually manage. But we should be looking at what was the reason first that we wanted to actually even have that policy in place, and how is it benefiting us? And therefore, if we've done that, then it gives us an opportunity to be able to reflect on the positive things on the policy and on the gaps that we are able to identify, for us to be able to actually intervene on the gaps and not scrap the whole thing just because we are uncomfortable with certain areas that we deem not being effective in that sense. I think that we have a bigger responsibility in terms of looking at this as more of something that is actually there to improve in terms of the retainment of the doctors that we actually have in the public service and stuff like that, rather than something that is a nuisance that we just want to get rid of because we are unable to monitor it. I do think that we are backwards in a lot of things, and there's a room for improvement in terms of, digital systems for us to be able to monitor, the RWOPS and the ins and outs of doctors and stuff like that. I think there's a lot of things that can be done in, as a matter of fact. And I think those things are the ones that needs to be explored to see if we can actually put this policy into a good standing. And I firmly believe, and I think this is my own personal belief, that actually there's a room that this policy can bring good rather than bad.
Oh, thank you. You mentioned something about digital technologies. Dr. Matiwane, was there any mention of digital technologies when you did your study?
Oh, okay. So in terms of like digital technologies, in what aspect?
To monitor.
Okay. Yeah. Okay. So in terms of monitoring, so from the studies that the interviews that I conducted, there was only one hospital which had a functional biometric system. So this hospital was then able to say, okay, fine, I can see that Mhlengi has been leaving early. His car sometimes at 2 is not there, at 10 it's not there. And then the hospital then was able then to go back to the system to see if Mhlengi was clocking in and clocking out at what time, and then take the necessary steps. And that hospital was the only hospital that was actually then took steps and actually told the person either go through this disciplinary hearing and then you stop. And then if the person then didn't stop, then the hospital manager would say, okay, fine, it's either you stop or then we then part ways. And then sometimes the hospital then lost a specialist. But the issue that the manager raised was that the biometric system was not linked to HR. So then, and also if you did not see that Mhlengi was there, then you will not know if Mhlengi was there. You understand? You have to go in the system and then manually check. So then she felt that at least if it was linked to the hospital, to the HR, so in private, then to say, okay, Mhlengi, you're supposed to work 40 hours and you've only worked 20, you're only going to be paid for 20 hours. So then there is no discussion. So I'm not going to have a meeting with you. You're just going to see your salary then reduced. And then you decide if you want to work less hours or not. So yeah, but then that was the only hospital. And then some other key informants, especially in Mpumalanga, complained that monitoring also became, supervision became difficult, because now it was difficult as a manager, if you have, especially in big hospitals where people then are working in theater, are working in, do you you understand? They were also teaching at a hospital, so it was difficult to actually monitor where they were. So at least if there was that biometric system, then you were able then to see if a person was actually at the time that they said they would be here, was actually servicing the hospital. Yeah.
Oh, thank you. Dr. Kumet and Prof. Mtambiro, would the biometric system be something that you'd consider practical for your hospitals?
Well, if I was to start, yeah, I think we already have some biometrics, especially at our university, and I think a lot of places do. I think it's a very reasonable thing, and I think it's going to be necessary. But we have to also link it with a lot of other digital activities, like, for example, paperless systems. Because I mean, some of the times we get into the hospital, you can get your biometrics, you go through, but then you get into the place and there's no files. So you're sitting around for 2 hours redoing files and various things. So I think the integration needs to be better. I think CETA particularly needs to get on board with this. But again, I think we're not a police state. And the point is, I think it also depends on what the person is doing. So just because you insist that the person arrives at 8 and leaves at 4, I don't think that makes much sense. For example, I mean, I do so much research and I have to go for various meetings. I'll be in and out of that hospital 2 or 3 times a day. How are you going to monitor it? And I think also with the overtime, I think we have to be very careful with the overtime thing. Remember that the Department of Health actually, it's actually it's a benefit to the Department of Health because the overtime was put there because they didn't want to have any pensional part. So it's not like it was a favor to give us overtime. We should be having a global remuneration, not based on this overtime. It should be global with monitoring, of course. But I think you have to be very careful about telling a clinician that, listen, you must be here at 8, you must go at 4. There are lots of other things that are going on, but Dr. Gumede, he runs the hospital, so maybe he can just jump in on board with that as well.
Thank you very much, Prof. I think for me, Mhlenge, is the issue of the biometric is supposed to be a standard way of doing things and moving from a paper-based system into, a more practical way of doing things. And I think it's more manageable than expecting somebody to go and sign down and every now and then and stuff like that. I think there's something that Prof actually mentioned, and to me, it actually resonates very well, is the issue of policing. I think that we as doctors, we have, not necessarily doctors, I think our RWOPS is always mostly associated with doctors, but I think it's about a policy that actually governs the public servants. But for me, it is always amazing how sometimes the problems that we see and the doctors that participate in RWOPS and stuff like that divorce themselves as responsibles in terms of ensuring that they remain ethical in this approach, in terms of their way of doing things. And I think for me, that trust is very important from my part. I think if I were to be manager and I'm sitting in a hospital where I know that my doctors are actually doing everything at their best to make sure that, the hospital is covered, patients are being seen and all of that, and there are no challenges when it comes to the supervision of junior staff. They're doing in-reach, they're doing outreach and all of those type of things. For me, I think that is the trust that we need to develop within the service in itself. And that goes a long way more than actually policing people in terms of where you are at this hour and where you are at that hour. I think that has got a far more reaching impact in terms of trust between us. And many times you may find that in your hospital, you may have 1 or 2, 3 people that actually just don't adhere to the policy in itself. And then now we make every other thing as if the policy in itself and the people that have actually applied for RWOPS are actually not adhering to this. And I think that there need to be a self-reflection from individual facilities to actually measure the scale of a problem when it comes to monitoring and supervision of these RWOPS. And that will give you an indication of how much problem you have. And I think that changing a system just because 2 people out of 100 people are not adhering to the problem doesn't solve it at all. If anything, it just deprives people that are actually willing to put in work and they're adhering to the protocols and the principles of RWOPS in exchange of the people that are just, not care, or they do not care about the issue of compliance to the RWOPS. So I think that it is up to us to be able to redevelop that trust within the system to ensure that we remain ethically committed to the service delivery, and make sure that whatever that we do, we remain committed to service delivery to ensure that our population, especially the vulnerable, especially the poor, are not actually again on the receiving end on this one. Public service is a constitutional right, and I think we all have an obligation to make sure that, especially in the public sector, we do provide services to the people the best way that we know how.
Thank you. Thank you so much, Dr. Kumete. And to everyone on the call, we have a survey that's running to elicit your opinion about RWOPS and what we should be able to say and should say on your behalf to the Ministerial Advisory Committee regarding RWOPS. Which takes me to perhaps one of the last questions that we'll have to deal with, and individually to our panelists, as well as to those on the floor. If you would want to type a comment on this, is RWOPS meeting its objective of retaining public service doctors in the public service system, and is it achieving its objective of retaining skills and skills development through the private sector? Yeah, thank you. I think we'll start with Dr. Kwinda, then Prof. Mutambirwa, and then Dr. Kumete.
Yeah, I think Mhlengi, it is basically it is a good provision in the Act, and I always avoid to mention policy because I don't understand why we are managing RWOPS through a policy, because that is not provided for in the Act. A directive is even better. I would even say it will even have been better if there was a provision for regulations to be made to deal with the issue of RWOPS, especially now when we understand the challenges that it imposes. As it is right now, it is not serving that purpose in terms of retention. And it's basically, as somebody said earlier, it's really a shared responsibility between the practitioners themselves or public servants and the managers, not just doing what they're supposed to do. And I believe that if we can start the issue of enforcement of RWOPS or managing RWOPS through the Act before we can talk about a directive or a policy, it will even be much better. As it is right now, it is not. Thank you.
Yeah, I must come in there a bit, Dr. Kwinda. I think it depends a lot on what we're discussing here, because I think it does assist with retention, to be honest. But I think it's a matter of discussion with each individual manager in the place. For example, we did Prof. Haynes, the late Prof. Haynes, and a lot of other people in 2012, I think it was. There was an assessment by the Department of Health about remuneration and whether private sector doctors are earning too much and they should restrict it. And the outcome actually showed that public sector doctors are earning equivalent, if not more, than private sector doctors in many ways, because they get paid overtime, they get maternity, all of these bits and pieces. But the point is that we have to then manage about how many people are going to be in and out. And the thing is that, especially when it comes to training, we have HPCSA rules. We have to make sure that we have a correct number of specialists for residents. We have to do a lot of it. So I think that it is worthwhile considering it. But I think one of the things, and maybe just to throw a pigeon, a pigeon amongst the wolf amongst the pigeons, is we've to try to balance this thing about training and getting things done. We've now come into a private-public partnership with Netcare, actually, where they're going to sponsor a resident, and the resident is then going to be rotating through my unit while one of my residents goes through there as well. It's difficult to do it, but the point is it's not impossible. And I think the most important part of this discussion today is the way forward. And I think we need to start having more public-private partnerships. we need to recognize that, because even like the RWOPS, if my resident, if I have to go and assist with the robot during the day hours of my work at the government, is that illegal? Is it not RWOPS? But I personally do believe that RWOPS has managed to maintain a lot of my staffing. So but it's about a discussion with them as well, so they understand what their responsibilities are. So I guess it's about management.
Okay, thank you. Thank you so much, Dr. Kumede.
Mhlengi, RWOPS as a policy, it was introduced with noble intentions, I think, but I think what is actually currently happening is that it continues to test the ethical, operational, as well as the moral resilience of our public health system. But I think when RWOPS was conceived, it sought to retain the scarce skills, as Prof is actually alluding to, supplement the modest public income. I mean, it's a contested point, as Prof has already mentioned, and also to encourage the collaboration between the public sector and the private sector. But in practice, I think what has been happening over time is that this has become a double-edged sword, where one hand, you are actually keeping the expertise in the system, but on the other, you are actually then responsible for improving accountability. It drains a lot of time and attention to actually deal with that issue without all of us taking accountability of what we are going through. And there is always a mention about RWOPS to say that, no, managers should manage RWOPS. And then we forget that actually, when you are doing your own RWOPS, the managers usually are not there. Your supervisor, whether it's a clinical manager, whether it's a head of clinical department, whether it's a medical manager, they're actually not there to see what you're doing and whether or not you are adhering to the hours that you've agreed to actually do. Hence, I believe that perhaps maybe the review of the policy as it is was done, the 2024 one, in terms of keeping a logbook, in terms of looking at what you do and how much hours you're putting in, comes in to actually clarify some of those issues. I do think that there has been an effort to try and answer the questions that most clinicians always have when they claim they do not have enough information about RWOPS. Somebody mentioned, I think it was Dr. Queen, who actually mentioned the issue of encouraging us as a collective to be able to have a debate on these issues. I think this engagement that we're having today is something that we need to have with multiple hospitals on different occasions, where we all of us understand exactly what are our obligations when it comes to RWOPS, and so that it can become a collective responsibility to ensure that the service delivery. I often say that whether a patient is a public patient or a private patient, they are all patients. They suffer the same disease, they require the same attention. And as soon as we realize that, I think that we would be in a better position for us to be able to be critical with our approach when it comes to intervention. In short, RWOPS, I think that it has a space, but at the moment, I think it has been compromised by the people that are not adhering to the principles that govern the ethical values of the same.
Okay, thank you. Thank you so much. I think Dr. Matiwane got an additional research question right there. Yes, and so maybe in our parting shots, may we deal with the fact that with a few things. Number one, does RWOPS stay? Does RWOPS go? If it goes, what do you think are the consequences for patients and for the medical profession? And number two, which Prof had already started responding to, is what is the recommended way forward regarding RWOPS? I think that will apply to everyone, starting with Prof and then Dr. Gwinda, Dr. Kumede, and then lastly, Dr. Matiwane. Thank you.
Yeah, thanks. I think Busi is probably the best one to take this on. She's done the studies. But I think, like Dr. Kumede was saying, I think it has been compromised, but I still think it has a place. I think in the ideal world, we should really be getting into our national health insurance or something, a global health thing. So there's no real incentive for us to do other things except be in the state. But I think the government also needs to come, the rest of the government, because I'm part of government, has to come on board, because I honestly can't understand how I'm supposed to, a unit is supposed to be able to function when we haven't got anesthetists and there are moratoriums on everything. And then you still expect the person to sit around drinking coffee. I think it's a bit of a problem. It's not just one side, it's a lot of different aspects. And I think we have to have a better discussion about the global changes that need to be made for our healthcare system so we can get a better care for everybody.
Yeah, from my side, Hlengi, RWOPS should stay. And what I will put in as a recommendation moving forward, let's start managing RWOPS from the Act, not from the policy. If everyone can take care of their responsibilities, let's manage it from there. And I think if we start there, because why am I saying that is because if somebody is doing RWOPS and they do not have a permission, and you recoup the money from them, even through legal proceedings, and where even you have to open a case, because when you read that chapter number 3, I think chapter number 7, people can even be arrested and be convicted and be imprisoned. If we can just start there in terms of moving forward with this matter, I think we can sort out most of the problems that we are dealing with. But I think now we are taking it down to a policy level instead of managing it first from the Act. It stays, let's start managing it from the Act.
Thank you so much, Dr. Kwinda. Dr. Commuted.
Mhlengi, I could have not put it better myself with what Dr. Kwinda has actually highlighted in terms of just about adhering to the principle, and that is in the Act, and it's stipulated there. In parting ways, I think for me, I could put it firstly as a way forward is to strengthen governance. It could be in a way of doing a thorough work when it comes to the annual renewals of RWOPS and looking into, what could be, things that are actually important to look at when we start renewing these RWOPS. And what do we look to when we assess whether somebody has been compliant, and what are the ways that we can actually tap into that enables us to be able to do this, including obviously what we've discussed about digital registry and stuff like that. But for me in particular, and I think I do want to emphasize this, is the issue of the reinforcement of the ethics in itself, the transparency and the disclosure, and the trust that we need to build in the public service with our managers and our colleagues as well. Because at some point, you will have other colleagues being demotivated by people that are not really adhering to this RWOPS policy. Now, I think the last issue is to also then start recognizing that teaching and outreach and all of those type of things are actually legitimate secondary work that we need to partake in. It's not all about, our, traditional way of just doctor-patient that we do in a hospital. There's a variety of issues that we actually do. And I think that we need to be able to be conscientized about all of this. Lastly, I think that we could actually do provincial RWOPS audit, as well as I think integrating RWOPS into the performance reviews. That will give us an opportunity to always see us in terms of, because we do our reviews, there's half-yearly review, there's annual review, and if we can tap into that as a form of review as well, I think it gives us an opportunity to reflect on how we have done with regards to the RWOPS with individuals that are concerned. It enables us to be able to manage it better. Thank you.
Okay, thank you so much. Dr. Matuane?
Okay, I think also the RWOPS policy should stay because it has some benefits. Because working in the public sector has its benefits, whether it's you being able to teach, getting pension fund, or you getting whatever benefits that you, like fringe benefits that you get. So there is a whole lot of benefit for people. That's why then people don't completely leave the public sector and just go to the private sector. That's why they have both jobs, because there is some benefits of working in the public sector. But I do also think that as the public sector, there needs to be, we need to optimize that benefit. So providing the resources for people to be able to actually implement those skills that they learned in private in the public sector. And then also making sure that, I think Dr. Gometa mentioned this, performance like effective performance measurement, like making sure that people are rendering the services, not the current PMDAs. But I think because now with the current PMDAs, you just like your manager just says, okay, let's go, you take. So I feel like it's also not like such an effective system, like having an effective system where we actually make sure that somebody is actually doing their job instead of because I think monitoring the ins and outs might, because we don't have systems in place now, but you can then monitor the performance while you're waiting for whatever biometric system to come in place, making sure that people actually do their jobs. If they're teaching, are they teaching? If they're supposed to be operate, are they operating? And then finally, what Dr. Quinda also mentioned is that implementing those like if somebody, because with the RWOPS policy, what I found in my studies that not every person, whether it's a health professional, whether it's a nurse, doctor, or therapist, not everyone is non-compliant. But there are people that don't even come at work at all. So dealing with those people first, so that actually then people think, okay, this actually is a valid policy. Do you understand? But then if now those people are not being dealt with, then everyone else follows and says, okay, I'm not going to come because so-and-so is also not coming. And especially if that person is senior. So what message are you sending to the junior people? So you're saying that it's okay, as long as you become a specialist, then you can do whatever you want because we need you. So then people need to be clear that in government, you need to be paid for what you are paid for. If you are not willing to do that, it's okay. Then we need to find somebody else. Because there is no point in you keeping someone, but they're not giving you the service, but then you're afraid to lose them, but they're not also not giving you the service. So I think those are the things, just making sure that you monitor, you actually supervise performance, that people actually do what they're supposed to do. And then finally, if there are any people that are not compliant, implement those measures, whether taking the money, reprimand them, like put it into action so that people see that it's not only written in paper, but it's actionable.
Oh, thank you so much, and thank you so much to our lovely panel. This was one of the best discussions that I've been part of. I'd like to thank Rainier at the background, as well as Naline, who's been supporting us, and to everyone online. Next week, same time, we're dealing with Rural Allowance and Community Service, and the following week, we're dealing with OSD. So please join us next week when we deal with Rural Allowance and ComServe, and we look forward to the final that will deal with the package of salaries through OSD. Thank you and have a lovely day. Oh yes, I forgot to acknowledge Dr. Pigisha, our Vice Chair, who is also here with us, and thank you for holding forth for a few minutes there. Thank you so much and have a blessed evening. Good night.
Thank you. Good night.
Thank you so much.
Bye.
Thank you very